So we received over 40 different abstracts to present here today. We selected 9 of the best and tried to get a diversity from the different schools to be represented. So we're going to feature 4 this morning, and then we're going to feature 5 in the afternoon session. So first up, we have Dr. Sahiti Myneni. She is an associate professor in the McWilliams School of Population. Thank you. Associate professor at the McWilliams School of Biomedical Informatics. Then we will hear from Dr. Casey Crump, a professor and vice chair of population health at the McGovern Medical School. Then we'll hear from Dr. Teresa Tran, the assistant dean for clinical population health and advocacy within the School of Public Health. And then Dr. Srila Sharma, a professor and vice chair of epidemiology and the director of the Center for Health Equity within the School of Public Health. So at this time, I'm going to turn it over to Dr. Myneni.
Hello, everyone. Thank you for this wonderful opportunity to speak and present to all of you the work that we've been doing at McWilliams SBMI, which is, it started off as a School of Health Information Sciences and then progressed into data science, AI, informatics, and we now have 3 departments: clinical and health informatics, bioinformatics, and health data science. So in that context, let me walk you through a couple of interesting studies that we have been conducting there at the school. So my agenda today, brief agenda, is to walk you through a digital health development framework that we have developed at SBMI, and a couple of case studies and opportunities in terms of collaboration and research that we might embark on in the near future. So I come from the Center for Digital Health and Analytics, in which we consider multimodal data sets that range from wearables, mobile apps, EHRs, and we strive to improve patient engagement, decision support, and patient safety across clinical and public health partnership with public health and clinical partnerships in place. So this is the classic data, information, and knowledge paradigm that we all are quite well versed with. Meaning, I've always appreciated the structure that the model presents us with, especially when we are working with diverse communities. But sometimes when we interact with our vulnerable populations or even diverse groups here in the state of Texas, we found that the complexities of patient priorities often don't get accounted for. And that's what led to DigiLego, which is a modular patient-centered framework designed to build digital interventions at scale. And the model itself brings together clinical context, behavioral needs, and social factors that ought to be considered when we design or try to develop scalable digital platforms for population health. And in that framework, social media is what I want to focus on as a primary research resource that we have been able to harvest following the ever-changing data license agreements, right? Like, for example, when I started in 2014, Twitter used to exist, and they used to publish open data sets on the web, which we could leverage to understand social and behavioral factors that patients self-report on social media. But eventually, the paradigm has shifted, and the data licensing policies that have come in place with the large language models, ChatGPT-like commercial solutions, have made it difficult for researchers like us to obtain data, very valuable, from social media. But navigating those changing policies, we have been able to harvest millions of conversations, all anonymous and all vetted and name scrubbed and de-identified in a variety of population health priority areas that we have just learned: substance abuse, type 2 diabetes, obesity, dementia, peripartum depression. And these interactions are not just unfiltered experiences that individuals put out on social media, but they also reflect the drivers or obstacles to health behavior modifications. Sometimes we've been able to document moments, stressors, unmet needs, and where is it that resources need to be built. Sometimes those that are not captured by traditional methods of inquiry or by the systems that we have in place currently. So using these resources, but I just want to sort of show you a couple of examples here. So these are conversations that we've been able to harvest when we're working on peripartum depression. Look at the first. All the apps celebrate pregnancy, but I'm scared all the time. No one gets it. This is from an individual who suffered multiple miscarriages, and none of the digital platforms that are out there at that point have recognized the fact and provided an emotional support at that point to that individual. The same with the third example. I told my OB I was tired and anxious, but I didn't mention we are skipping meals to afford diapers and meat rent. So certain times, taking care of self, especially during motherhood, can be a daunting task because in cultures, in different generations, that self-care is sort of stigmatized and baby is supposed to be celebrated, right? So oftentimes women don't disclose their symptoms or their feelings to clinical partners or their family relationships. And they come to these sources where they expect to find some kind of lived and peer experiences. And that's essentially what we have been trying to cull through to understand what are these unmet needs. And with these data, we've been trying to understand what are individuals' intent, what are their needs, how do they interact with the information environment that they are surrounded with, either in digital form or in their family relationships. And how can we then use those understandings to identify outcomes and priorities that could inform our population health interventions. And to do that, we use a variety of methods, but I'm going to give you a very brief overview of what we do. We start with theory. They can range from psychological, behavioral, social sciences. Then because social media has billions of interactions, and much of it is noise. So if we want to be efficient and scalable, we need to contextualize our understanding. And for that, we utilize recently developed AI models, data science algorithms, and try to make it easy for the researchers to make sense of that large-scale data set. And finally, we try to understand how these different variables come together at population scale. How do ideas transmit from person to person? And how do they install barriers or address gaps? What can we do that is instrumental, or how can we build innovations around those unmet needs that we've discovered? So with all that methodologies in place, we then develop intervention. So now that we have grasp of patient priorities, barriers, at a very large scale, we then localize them to the populations that we truly want to intervene. And for a classic example here is we are now developing chatbots. This is for women with gestational diabetes, and women with gestational diabetes are highly prone to peripartum depression. And we are trying to provide them with personalized education, tiny nudges to make nutrition changes, to take a walk for immediately 30 minutes after a meal. And we make it in a way that is more humanistic rather than prescriptive. And we've also done similar analysis in tobacco cessation. What users, here on the screen, you see users who are trying to quit smoking, who are relapsing, and then we try to understand what is it that these people are talking about. For example, in this network, traditions mean when people come together to quit smoking in a virtual network, they established a tradition where they donate their unsmoked cigarettes to a virtual bonfire. And that's their every Monday evening routine. And that's not just a tradition, that sort of also symbolizes a lot of behavioral constructs, including observational learning, rewards, incentives, social norms. And looking at the messages that were exchanged, we tried to model the influences that individuals had on one another and how best to harness those influences to develop interventions. We've also built a health promotion platform called Habit Hubs, in which we share healthy living and lifestyle-related messages. And at one point, we did collaborate with our UTHealth Office of Employee Wellness to bring this to scale to all faculty and staff here at UTHealth. And then wearables. How can we integrate wearables and also add some ground truth to patient-reported health behaviors? So we've been able to use sensors. The only issue is who manages those data, and who pays for those devices, right? So that's a critical barrier that we haven't been able to transcend. But we do have the skill sets in terms of if you have an idea as to you want to use a wearable to obtain some ground truth about a behavior, we could develop that into a full-blown application that you could then go out and test in specific populations of need. And more examples for peripartum depression. And we also did some YouTube video series production to make knowledge accessible on emerging digital media platforms. Overall, in a nutshell, this is what we've been doing at SBMI. How can we leverage social network as a health multiplier? How can we take those conversations and move them to actions, leveraging AI and implementing large language models with human in the loop? And how can all those insights provide us with just-in-time health communications that are tailored to meet individuals' needs? And parting thoughts, I'm always interested in collaborating with interventionists who are interested in developing new content, leverage social media platforms, implementation science, of course. So like I said, I'm a methodologist. I'm keen to take those methods and make an impact. So if you're interested, please reach out to me. And these are all the individuals I work with across the schools at UTHealth. With Dr. Fernandez, Dr. Shigog, they have been instrumental in guiding this work and helping me tailor these methods for high priority populations. Our funders. Thank you.